Hello friends, welcome to Health, Music and Fitness channel. Today we'll be discussing a very interesting ECG. It's the ECG of one of my patients who came today with chest pain and palpitations. And this ECG has a lot of finding, as there's wealth of information in this ECG. And if you know how to interpret it, it is like ocean of findings. So we'll start the ECG, but before that, you should know that you have to go systematically, and we cannot bypass any of the steps. In the previous ECG, I have told you you have to look at the calibration and then the rate, rhythm and axis. Okay, don't bypass these steps. And because most of the times what we do is we hold the ECG like this and we start looking for MI or a left bundle branch block or a LAHB or something like that. And that is a time we make mistakes, and we miss a lot of findings in the ECG. Because in one particular ECG, there can be various problems at various levels and in various intervals. Okay, so like one patient's ECG could be having SA block, and in the same patient's ECG, there could be atrial flutter, atrial fibrillation, flutter fibrillation, both could be present together. And in the same ECG of the same patient, there could be AV block or a junctional escape beat. And along with these findings, in the same ECG, there could be a left bundle branch block or a right bundle branch block, or there could be LAHB and a RBB bifascicular block, or first degree AV block and a LBB. So that is also bifascicular block. Plus with these, the same patient could be having VPCs, and this patient could be having all of these findings. Plus this patient could be having ischemic changes, Prinzmetal's angina, or maybe inferior wall changes of MI or extensive anterior wall, or this patient might also be having left atrial enlargement or biatrial enlargement. So you see, your imagination is the limit. Okay, plus this patient might also be on digoxin, and this patient came with vomiting also, let us say, and he or she might be having digitalis toxicity signs also. So, and plus you can just keep on thinking, and this patient could be having so many findings. So it's just not just MI. You might be giving potassium to this patient because she's on digitalis, and she might have come with hyperkalemic changes. Okay, so now you see there is wealth of information, and our imagination prevents us from lack of imagination prevents us from looking at those findings. You have to be like a detective when you interpret the ECG, and just hold it, interpret, go step by step, rate rhythm axis, P waves, PR interval, QRS, QT, ST, T, okay, like that. So we'll start the ECG. This is a very interesting ECG. We'll come to this circle later on, and this is one of my favorite slides I show in almost every lecture, because this is the DNA of the ECG. And you have to plot, you have to train your mind to plot all the findings, all the complexes which you are seeing like this in the ECG rhythm on the circle. Your brain has to be trained in such a way, while you are doing this, while you are seeing the complexes, automatically, subconsciously, you should be able to plot these complexes out here on this circle, and then it's very easy to interpret. So we come to this ECG. Now you see, first you have to look at the calibration. Okay, calibration is very important, because if the calibration is not proper, you could miss a lot of findings. ECG could be showing fake R waves, fake S waves, fake Q waves, and your interpretation might totally go wrong. So a normal calibration should be 10 small squares in height, a horizontal plateau, and a vertical fall of 10 small squares. Okay, and we calculated 0.1 millivolt, 1 small square, and 1 millivolt is 10 small squares. So that's about the calibration. Okay, because supposing your calibration is going like this, like this, like this, and like this, you might get a false R wave, and this patient might be having ischemia. R wave progression might be poor, but because of this wrong calibration, this patient ECG will look better than what it is. And on the other hand, if you're getting a complex like this in the calibration, you might get a wrong S wave or a Q wave. So that is, see, it is so important to have the calibration right. And sometimes the machine will make the calibration just 5 small squares in height. And in that case, supposing the R wave in, let us say, in V5 is 20 with a calibration of 5, then actually the R wave is 40 small squares in height. So you see, it is that important. So once the calibration is okay, then you calculate the heart rate. Now in this patient, you can actually see the heart rate is irregular. Right from MBBS days, we have been trained like irregular heart rate is atrial fibrillation, and 99% of the times we are right. There can be many other reasons for irregular heart rate. There can be type 2 AV blocks and a lot of PACs and with VPCs and mixed VPCs plus PACs, and heart rate can be irregular. But most of the times, in 90% of the cases, irregular heart rate you will see in atrial fibrillation, and this is the ECG of a person who is having atrial fibrillation. Now, right now, okay, one more thing you have to remember is many times we make a mistake by we say if the P wave is visible, we will say it's a normal sinus rhythm. It is not true many of the times, because a normal P wave, when it is a normal sinus rhythm is when it is coming from the SA. The impulse is coming from the SA node. In that case, you will get a very good positive P wave in lead 2 and a biphasic good P wave in V1. Okay, where the left and the right atrial components are separated because it's biphasic. So the positive component of the P wave in V1 is right atrium. The negative component of P wave in V1 is left atrium. So if you want to comment on P wave, V1 is very good, and also look in lead 2, because lead 2 the vector is directly directed towards lead 2 positive pole, so it will record a very good P wave, very good QRS complex, and very good T wave. So now we are looking at, and because sometimes what happens is you will see various shaped P waves, so that is not normal sinus rhythm. It could be rising because of multifocal atrial tachycardia or PAT or MAT, and multiple premature atrial complexes are arising from the atrium. So in that case, the impulse is not from the SA node, the atrium is firing. So even though there are P waves, it doesn't mean it's a normal sinus rhythm. Okay, so this is very important. So in this patient, you see the heart rate roughly if you want to calculate, so 300 divided by number of big squares between two RR intervals. So you can take RR intervals, so 1, 2, 3 big squares. So roughly the heart rate is around 100. Okay, so it's okay, it's around 100. But if you want to calculate accurately the heart rate in atrial fibrillation, then you have to use that method which I taught you before in the previous ECGs. So 1500 divided by number of small squares between two RR, or 300 divided by number of big squares between two RR, that is for conventionally normal ECG without irregular heart rate. But if the heart rate is irregular, then you have to do this. One small square is 0.04 seconds in duration. There are 5 small squares and 1 big square. So 1 big square is 0.04 into 5, 0.2 seconds. So 0.20 second is 1 big square. How you will make it 1 second into 5 big squares is 1 second into 6 is 6 seconds. 5 big squares into 6 times. Okay, so 6 seconds. So you calculate the number of R waves in those 6 seconds duration and you multiply by 10. 6 tens are 60. So 1 minute has 60 seconds. So that will give you the heart rate, how many times the heart is beating in 60 seconds, because the pulse rate will be different in atrial fibrillation and the heart rate will be different, and you will get a heart rate higher than the pulse rate, and that difference will be the pulse deficit, and pulse deficit of more than 10 is usually significant. So you see in this patient's ECG there is atrial fibrillation, irregular heart rate, and you cannot see the P waves. It is a wavy isoelectric line. That is very classical of atrial fibrillation. Right now we are just at the atrium level. Okay, there are a lot of findings in this ECG. Now you see in out here in AVF, it's a sawtooth pattern. Okay, so this is flutter and this is flutter. Okay, so this is sawtooth pattern. So it's flutter fibrillation. So when there is atrial fibrillation and atrial flutter occurring together intermittently, so you can call it atrial flutter fibrillation or atrial flutter with fibrillation. and heart rate is rather fast only. So you can say atrial fibrillation with fast ventricular response with intermittent flutter waves, flutter rhythm. Okay, so now we have come to the atrium, and and you can take your time. There is no need to be in a hurry. Okay, like right now I'm making the video and I'm just looking at the ECG. I should not be in a hurry. So I have to set an example. I have to relax. And now see, I have always told you before, if something is positive in AVR, something is very bad occurring in that ECG. Out here, ST is elevated. Okay, so ST is elevated, and there's a lot of abnormality at the atrium levels, and there is an interventricular conduction defect. You can see this notching of the R waves. So that is called IVCD, interventricular conduction defect. Okay, right now we are at the atrium. Okay, now we look at the axis. Rhythm, rate, rhythm we have covered. We come at the axis. Lead 1 is positive because there is hardly small, very small S wave. This is the R wave. So now we'll come back to this picture. So lead 1 is positive. Positive pole of lead 1 is at 0 degrees. Okay, so we have plotted it out here. And the negative pole is out here. So lead 1 is positive. Now we come back. Look at AVF. AVF is very deep, negative, very small R wave, very deep S wave. If we go back, AVF positive pole is out here, negative is out here. So we plot it out here. So the axis is in this quadrant. So this is the left axis deviation quadrant. Okay. Now I will show you how to diagnose it almost like a computer, like a TMT machine, how many degrees. Okay. So now we have concluded that axis is left axis deviation in this ECG. Now you look at the most isoelectric complex in first 6 leads. Lead 1 is R positive, lead 2 is deep S, lead 3 is deep S, and AVR, AVL, AVF. So there is no lead which is isoelectric. Had there been an isoelectric complex in the first 6 leads, the axis would have been lying perpendicular to that. Okay, you could have drawn that diagonal and the axis would have been that. Now you see, if we come back here, now lead 3 positive pole is at plus 120 degrees. Okay, so we come back. Now you see lead 3. There is very smaller, but there is a very, very, very deep S wave in lead 3. So which means the impulse is sort of almost whole of the time it is going away from the positive pole of lead 3. That is why there is a very deep S wave. For the whole of the time when the impulse is going away from lead 3, it is directed towards minus 60 degree because lead 3 positive pole is at plus 120 degree. And the straight line across the center of this circle will be minus 60 degrees. And I told you all the leads are lying at multiple of 30 degrees. 30, 60, 90, 120, 150, 180. Similarly on the negative hemisphere. Okay, so the axis is lying somewhere in the left axis deviation quadrant where lead 3's negative pole is plotted, and the negative pole of lead 3 is plotted at minus 60 degree. We come back. Now you look at the most isoelectric. Let us say we'll try to find the most isoelectric complex. So there is no isoelectric complex. Okay, so now I will conclude that the axis is left axis deviation and it is around minus 60 degrees. Okay, because lead 3 is almost negative. It is totally negative. Very, very deep lead 3. See again, lead 3, very deep S wave. Lead 2 also has S wave, but it is not that deep. Okay, so we'll come to the axis degree which the machine has calculated later on. I know it, but I will show you later on. Now you look at the QRS complex duration. Okay, so it is not more than 3 small squares. So it is not LBB, it is not RBB, it is not a VPC. Okay, so atrial flutter is there, atrial fibrillation is there. But there is a left axis deviation. So common causes of LAD are left frontal branch block. In that QRS has to be broad. It is not that. LAHB, left anterior hemi block. There you will get deep S in 2 and 3 and axis deviation of more than minus 30 degrees. Okay, and QRS is narrow. It's less than 3 small squares. Deep S in 2 and 3. So this is left anterior hemi block. So this is a third finding. And now we further again look at the complexes out here. In V1 you see P wave R, S R dash pattern, rabbit's ear. So one R is small, one is big. Okay, so that is called rabbit's ear, that you will see in right bundle branch block. Now I have told you left ventricular electrical activity dominates the right ventricular electrical activity, and this is what we are seeing out here. There is a right bundle branch block, but the axis is left axis deviation, and because this patient has LAHB also, so the right bundle, right sided activity is sort of suppressed. Okay, so there is a right bundle branch block with left atrial hemilog, bifascicular block, atrial flutter with fibrillation, and there is an interventricular conduction defect. Okay, and so we come here in V4, V5, V3, V4, V5, V6. There is a R wave. Okay, R wave in tall R rather. Okay, so but the ST is depressed. ST is sort of down sloping. This patient could be having a lateral wall ischemia or anterior wall ischemia, and see this ST, and T is inverted. It could be because of left ventricular hypertrophy with strain pattern, but to be it looks like more of ischemia also. Okay, and the machine has interpreted as sinus tachycardia, sinus arrhythmia, premature ventricular complexes, incomplete RBB. Okay, most of the times it will be a wrong incomplete diagnosis by the machine, so you have to use your discretion which of the diagnosis to match to your diagnosis. Okay, don't read this diagnosis and go by that. Now see, we had calculated the heart rate is around 100, machine says it is 104, and this is the axis. Okay, so the machine has determined the axis is -58, and we had calculated as -60. Okay, so we are very, very accurate, almost as accurate as a TMT or a computerized machine, and it feels great when you find out the axis and detect lot of abnormalities in the ECG on your own. And you should interpret at least 100 ECGs, and actively you think of this circle. Okay, always, and interpret 100 ECGs and plot them on this circle. You can actually have this printed out and keep it in front of you at least for 100 ECGs. By that time your brain will start mapping all the findings on this circle whenever you will be holding an ECG. So that's it about this ECG, guys, and thank you for watching, and please do subscribe to my channel if you haven't done so already, and share my videos with your friends and colleagues, and also in other colleges. If you are watching, you may subscribe to my channel and share my videos, medical videos, with your friends and medical students, and let them also benefit. Leave a comment, and if you find some other abnormality in these ECGs, please go ahead and post it in the comments. I'm always willing to learn, and a student is always a teacher, and the teacher is always a student. So like I always say, God, Guru, and the self, we are all one. Okay, everything is inside us only. We have to be willing to humble ourselves and learn and become the teacher in that instance, and again we'll become a student. Okay, so thank you so much for watching, and bye bye, good night.